Any pregnancy where the fertilized ovum gets implanted and develops in a site other than the normal uterine cavity is known as ectopic pregnancy. Then the ectopic pregnancy is due to any factor that causes delay in the transportation of the fertilized ovum through the fallopian tube, favors the implantation in the tubal mucosa itself, thus giving rise to the tubal ectopic pregnancy. These factors may be congenital or acquired. Congenital factors include tubal hypoplasia, congenital diverticuli, accessory ostia, or partial stenosis. In acquired factors could be inflammatory like PID, septic abortion, MTP, surgical, tubal reconstructive surgery, recanalization of the tubes, neoplastic broad ligament myoma, ovarian tumors. Now, the sites of ectopic pregnancy, there are various different sites on which the fertilized ovum can be implanted, and on the basis of that there are various types of ectopic pregnancy like fimbrial ectopic pregnancy, ampullary, isthmic, interstitial, ovarian, cervical, cornual, then secondary abdominal, broad ligament, or primary abdominal ectopic pregnancy can be present. Clinically, ectopic pregnancy remains asymptomatic until it ruptures, when it can present in two variations, and that is acute and chronic, and the symptoms involves amenorrhea, abdominal pain, syncope, vaginal bleeding, or pelvic mass. The diagnosis of ectopic pregnancy is by using the various methods like immunoassay utilizing monoclonal antibodies to beta HCG, ultrasound scanning, including the color Doppler, laparoscopy, serum progesterone estimation may be helpful, or TVS, can visible a gestational, or can be visualized to a gestation sac as early as 4 to 5 weeks of from LMP. Then during this time the lowest serum beta HCG is 2000 international unit per liter. When beta HCG level is greater than this, then there is an empty uterine cavity on the on TVS, and ectopic pregnancy can be suspected. And the management of the ectopic pregnancy depends on the stage of the disease and the condition of the patient at the diagnosis. And the options could be surgery like laparoscopy or laparotomy, medical administration of the drugs at the site, oblique systematically, and expectant could be the observation. They leave the patient for the observation period during the ectopic pregnancy. And management of acute ectopic pregnancy is hospitalization of the patient, then the resuscitation, the treatment of the shock if the patient went into the shock, then lie flat with the leg and raised, analgesics are given, and the blood transfusion is also there. Cultocentesis, it is the most helpful in emergent situations to confirm the diagnosis, highly specific if performed and interpreted correctly. Then presence of free flowing or non-clotting blood, then negative tap inconclusive, and it remains controversial. Then the management of chronic ectopic pregnancy, it is serial quantitative beta HCG level is checked, then serum progesterone level, then the low levels of trophoblastic proteins such as SPI or PAPP are checked. Then USG, usually the hematocele is found, and then the laparoscopy is there. And salpingectomy of the offending tube can be done. If pelvic hematocele is infected, then the posterior colpotomy is to be done to drain the pelvic abscess. Then salpingo-oophorectomy is also done.